Well, the next session will be mine on pulmonary coccidioidomycosis. I want to thank Rebecca for that excellent review of the epidemiology, and it's so exciting to see the state and CDC remain very interested in this disease because as she depicted, this is a very, very important disease for our state. Now, this is another way of looking at infection with coccidioides, and this is from my friends Theo Kirkland and Josh Fearer. They published this a few years ago. And I want to emphasize, because it's absolutely true, we believe fully 60% of all people who become infected with coccidioides have no symptoms. And that was shown years and years ago by Smith doing skin test studies. And I've actually observed that and am an individual who did asymptomatically convert. And as Rebecca mentioned, those individuals, by and large, have no other problems, and they remain immune lifelong. Then we think maybe 35% have a symptomatic primary pneumonia, which is maybe very indistinguishable from a bacterial community-acquired pneumonia. Some of those people, maybe 5%, have what is truly valley fever, because that was the original name of this entity in the San Joaquin Valley fever, where people had a pneumonic syndrome, but also had a rash, either erythema multiforme or erythema nodosum. That's actually where the term valley fever comes from. And then, as Rebecca mentioned, there's this big debate. 5% have chronic management issues. We think fewer than 1% actually disseminate, that is, have clinical disease outside the thoracic cavity. But then there are other patients with pulmonary diseases that have management issues. So the vast majority of cases of valley fever resolve and are not a clinical problem. But because there are so many instances occurring, that 5% looms large as an absolute number. So we've already gone over, the common presenting symptoms, and I'm going to give you a little different prism, and I am going to mention the two studies that Rebecca mentioned, but as a clinician, I'm going to give you a feeling I have that if you really think about it, you can pick out cases of valley fever clinically, even though the studies don't show that. And there's a reason for that, because studies are just collecting data, but you're actually interacting and seeing a patient. So I'm going to go over that. And we've gone over these symptoms: cough, pleuritic chest pain, fever. Most valley fever is actually acute, occurring over days. And as we've mentioned, it's very difficult, or can be difficult. And these are the papers already mentioned. Here's the Lisa Valdivia's paper, and I'm not going to go over that except to say what was interesting about this is that 16 of these patients were seropositive. That is a debate about this particular paper, because did that serology represent the episode that brought them into the emergency room, or was it lingering positive serology? But one of the interesting points of this study is all the patients who had a positive serology and did get multiple courses of antimicrobial or antibacterial agents, none of them ever got treated for valley fever, and all of them did fine. And that's one of the points to emphasize, that most cases of primary pulmonary coccidioidomycosis do just fine without any therapy. And then we also mentioned the Kim paper that Dr. Blair was a co-author on, and also demonstrating that maybe a lot of these cases of primary pulmonary that we presume to be a community-acquired bacterial pneumonia are in fact valley fever. And again, it gives you that sense that many of these cases don't require treatment and get better on their own, and might not ever be diagnosed if you didn't look real hard. So what are the things, if you're sitting in clinic, that might suggest to you, and again, none of the studies ever find this, but I will tell you as a clinician, when we see patients in clinic or we're seeing them in consultation, these can be helpful. So patients will often tell you they have night sweats. Now, night sweats are difficult to ask about in Arizona, maybe not today, but in the summer. Because if you're not sweating at night in the summer in either Phoenix or Tucson, you probably have an endocrine disorder and should be checked out. But true night sweats are an exacerbation of the normal warming in the early hours of the morning. And so what you want to ask about, are you really just soaking the sheets and soaking your pajamas? And you will pick that up. And I've actually have myself stopped in the tracks when either a patient volunteered that information or I asked about it. And that is something that probably one doesn't see in a bacterial community-acquired pneumonia. Fatigue I'm going to go into because we did a study, but that is worth asking about as well. Because again, patients with a bacterial community-acquired pneumonia won't really tell you that they're fatigued, that they have trouble doing their activities of daily living, yet it's such a common phenomenon in valley fever. The rash we'll talk about. Headache. Now, headaches are have been frequently noted with primary pulmonary coccidioidomycosis. There's nothing specific about them. They don't mean that the patient has meningitis, and one wants to be careful about that, and I think Dr. Blair may talk about that. But it is part of that syndrome. A loss of weight. Again, if this is a severe case of valley fever, people tend to feel fatigue. They lose their appetite. And then the symptoms in the ones we really pick up in clinic or in consultation, these symptoms are going on and on. So again, I'm a believer that a lot of cases are fleeting and we never pick them up because patients get better. But when they don't, these are sort of some of the things that really start to suggest this might be valley fever and not just a simple bacterial process. Now, there are a series of rashes associated. And one is a rare one, and I hope my slides come through, that I've rarely seen, and that's toxic erythroderma. That usually occurs in younger adults or children, and it's just this diffuse red scaly rash that is very nonspecific. But the two you want to really know about for valley fever are enodosum and E. multiforme. So enodosum is almost always these red or violaceous, painful nodules on the lower extremities, usually the shins. Most common in women, but we've seen it in men, usually in young people. I can tell you we've picked up several house staff, University of Arizona house staff, who've developed primary pulmonary coccidioidomycosis because they complained about having enodosum. And enodosum is felt to be a manifestation of cellular immunity. So it's sort of the body's own way of, in essence, reacting to the skin test. And so the data do support that people who have enodosum usually have a benign course. That's not always true, but it does seem to be the case. It's more common in women. Dr. Sonnenschein already told you that women tend to do better with this disease and are more likely to have enodosum. Now, E. multiforme is much less common. And that's, of course, these target lesions. And in cocci, the target lesions are frequently in a necklace distribution. And I've seen this where patients come in and they'll have these targeted lesions around the neck. I've seen at least one patient receive corticosteroids for that. So if you see either a necklace rash or enodosum, these painful violaceous lesions, think coccidioidomycosis, get an X-ray. Because you'll see then in those cases, a pulmonary infiltrate, even if the patient isn't complaining of that.